Hello, this is Crystal May, and thanks for joining me for this webinar. Wanted to talk to you a little bit about the effects that sleep has on health and the whole body, and the importance of the dental office in screening patients, and how 5 minutes in new patient or hygiene can save the life of one of your patients. So I hope that I just shed some light on how sleep affects overall health, how you can explain it to patients in an easy to understand way, and give you some verbiage and some suggestions on how to introduce this to your patients and into your practice. So this webinar is being recorded and will be available on demand. So it's in the next few days. If any of your team members aren't able to watch it live, you'll be able to access it on our website at devdent.com, and it's available on demand for you to watch again in the future or to share with others. Also, at the end of this presentation, you'll be sent a free resource. So we've created a resource that explains how sleep affects health, something that you could have available in an operatory or share with a patient to help visualize how important this is and the role that sleep can have on health. So that'll be emailed to you automatically at the end of the presentation. So there's nothing you need to do at all, just wait for it to come in your email, and it'll be sent to whatever email you use to register for this event. So on the lower right, you'll see a chat box. If you have any questions throughout the presentation, you can just put them there. At the end, I'll save a little bit of time and try to go back and answer your questions. If you have questions that are beyond a simple Q&A, you can always email them to support@devdent.com, and one of our customer service reps can either answer your question or forward it to one of the coaches who can answer that question for you. So let's get started. So a little bit about myself. My name is Crystal May, as I mentioned, and I'm the COO at Devdent. And I started in medical billing first in medical practices, and I helped manage and set up medical specialties, all different ones, and really got my hand in that. And then I had the opportunity to get into dentistry, and really thought I found my new passion or the future profession I wanted to be in, and took it very seriously and had the opportunity to own several practices, and just loved what we were doing for patients and loved the atmosphere. But then I took my first sleep course, and I really had my eyes open to how sleep and dentistry and sleep and health all fit together, and the role that the dentist could play, and decided that was actually my new passion. And so about every 5 years, I guess, I find something new that really catches my interest. But sleep has been about 10 now, so I think it's going to stick. So for the last 10 years, I've just spent all the time I can researching sleep and health and dentistry and the role that dentists can play, and really saw how we could change the lives of patients and change our practice. And so as a company, we decided that we needed to share this, and we needed to build solutions for dental offices to be more efficient and effective in implementing sleep and billing into their practices. And so everything we've built is with that in mind, that our industry as a whole needs to better understand our role in health and sleep. And that's what we focus on. So Devdent stands for Developing Dentistry, and our statement is that we are determined to innovate dentistry, providing advanced education, support, and effective solutions to improve dental offices and the well-being of their patients. We do that through education, webinars being just one small part of it, but 2-day courses and on-site training. We have full software, and then we have a full range of customer support, team training, consulting, and coaching. So that's how we're here to try to make a difference in the industry. So just a little bit of basics, so we're on the same page. So obstructive sleep apnea, very, very simple. It's an anatomical event. When you fall asleep, the muscles relax. The muscles that hold the tongue forward relax. The genioglossus muscle is attached to the mandible, and when muscle tone is lost and things relax, the jaw falls back. Therefore, the muscle that holds the tongue also relaxes, and it causes that tongue to block the airway. And so the narrowest part of the airway in the upper airway system is just behind the tongue. And so when that tongue falls back, it's very easy for it to be partially or completely blocked by the tongue. But also the tissue around the airway itself, and the muscles lose their muscle tone as well. So it's a combination of the airway actually getting slightly smaller because of lack of muscle tone, and the tongue falling back and blocking it. So just so you understand the difference. So normal healthy breathing, you're breathing in through your nose, The air is following that path down into the lungs. What's happening in an obstructive airway is it doesn't matter if you're trying to get air through the nose or air through the mouth. If the tongue falls back and blocks that airway, the air can't get into the lungs. So that is obstructed airway. So we define sleep apnea based off of the amount of incidents you have in a given hour. And so what it is you fall asleep, then you go into an apnea or hypopneic state, which means the tongue is fallen back, the muscle tone is lost. When that happens, there's not oxygen flowing, so the oxygen starts to desaturate, so your O2 falls. And then your body goes into a fight or flight response. Adrenaline is released and it says, wake up, or you're going to die. So our body actually causes an arousal, and this is something that's happening automatically to try to prevent death. And so sympathetic activation is happening. So flight or flight, body says, wake up, or you're going to die. So your body arouses, but you don't actually wake. Your eyes don't necessarily open. You generally have no recollection of this happening, but your body changes its sleep architecture enough to breathe. And so you breathe, you take a few breaths, sometimes only one or two, and then you go right back into the sleep apnea cycle. So each one of those is one incident. So that's one sleep apnea incident. And you do have a few parameters. Your oxygen has to desat by 4% or more for 10 seconds or longer. So it's not like if you hold your breath for a couple seconds that you're going to be considered apneic. You actually have to have a desaturation that lasts longer than 10 seconds. So to calculate the severity of apnea, we take the total number of those incidents or events, add them together, we divide them by the total numbers of hours of sleep, and that gives us an index. It's called the AHI, or the apnea-hypopnea index. And this is a way to standardize severity of apnea, and it's not a perfect calculator, but it's what we have. And so if you have 5 or 14 of those incidents, those desaturations, sympathetic activation incidents, then you are considered mild. 15 to 29 is moderate, and 30 or more is severe. So again, just very basics of sleep apnea and how we calculate it and its severity. So as we talk about health and how we incorporate this into a dental practice, something we have to all agree on is that sleep is the foundation of health. And that it doesn't matter how well we diet or how well we exercise. If we're not sleeping well, it affects the entire body. And I'm going to show you how and how you can explain this to your patient. But this is something you need to really be believing in and committed to in order to explain this to a patient. And we've all had those situations where we had a bad night's sleep and we wake up feeling terrible, but it's so much more than that. This has a long-term effect on health when you're not sleeping well. So I'm going to explore that as much as I can. So we teach this in a simple way to try to make it make sense. And it's not just quantity of sleep. It's not just do you even wake feeling rested, but it's the quality of sleep you get and how it affects our entire life. So we divide this into 3 stages of sleep: light sleep, deep sleep, and REM sleep. Light sleep is pretty non-productive, it's non-restorative, it doesn't have anything really good happening in it. But deep sleep is the time that our body's hormones are regulated. This is a really critical part to health, is our hormone regulation. This is also when our immune system repairs, we get our energy. This is where we feel rested and have the energy when we wake to complete our day. But there's even hormones that are released during night, leptin and ghrelin, that regulate your appetite and your need to burn fat versus store fat. So if someone's not getting deep sleep, it can actually, it will increase their weight gain, and it'll make it very difficult for them to be effective in weight loss programs if they can't improve their deep sleep. And then REM sleep, we're all somewhat familiar with or have likely heard it. Most people think of it as this dreaming sleep, but it's also what we call brain sleep. So this is when everything cognitive and brain function is improved and when memories are stored and organized. And so this is where we see people really struggle with cognitive function if you don't have good REM sleep, and this can be adult or adolescent. But when you are just struggling to even remember things. You probably are suffering from a little bit of REM deficiency. You're not quite getting as much REM as you should. So very simple, deep sleep equals body sleep, REM sleep equals brain sleep. So we have all seen the articles. You just about can't go to a major publication and not read something about sleep. On an airline, every magazine has something about sleep. On the Wall Street Journal, everything has something about sleep. And so here's a few statistics that you can use. So more than 20 million Americans have obstructive sleep apnea. So it is a nationwide epidemic or problem. But you're estimated to have 20 less years. Your life expectancy is actually 20 years less than that of a person who doesn't suffer from obstructive sleep apnea. So that's a big deal. In light of October being Breast Cancer Awareness Month, severe OSA patients are 5 times more likely to die from cancer. So the mortality rate, not even just the rate on which they might get cancer, but their survival rate. So you don't respond as well to therapy, and the mortality rate is 5 times higher for an OSA or obstructive sleep apnea patient suffering from cancer. 23 times more likely to have a heart attack. And the real scary thing, and the reason that dentistry has such an important role to play, is it's estimated that at least 80% of apneic patients are still undiagnosed. So that 20 million Americans are those who have been diagnosed. So 80% of the general population that has apnea have not gone through the steps to actually be tested and diagnosed. So, I ask you, how is that any different than your patient population? And it's not. These patients in your practice are within these statistics for sure. So we often talk about this, and poor sleep affects the entire body. We have all these statistics, and I'm going to go through them in more detail, but just wrap your head around this for a second. Hypertension, stroke, obesity, sexual dysfunction, coronary artery disease, congestive heart failure, likelihood of sudden death. So this is just telling you that they have clinically proven that poor sleep, and specifically obstructive sleep apnea, has affected all of these major body functions. So when you have a patient who is coming to you with a long medical history, you can look at these and start to say, yes, 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 the likelihood of this patient having obstructive sleep apnea based solely off their medical history is great, is a really high percentage. I find that I have a lot more confidence talking to my patient about these health conditions if I have a better understanding of them and how it's related to hypertension or heart failure or any of these other conditions. So I'm going to spend the next few minutes just trying to explain to you how obstructive sleep apnea affects the body, and then give some talking points to explain it to a patient. But again, we know that we see hypertension every day in our practices, heart failure, stroke. I mean, there's just not a much worse health condition to have gone through than to have a stroke. And then the sudden death, we don't die peacefully of natural causes in our 50s and 60s. There's something going on. And every few months, we have someone in our community or our patient base who dies. And it's the 50-year-old patient who was not necessarily active, but wasn't necessarily terribly unhealthy, and they didn't wake up. And it's obstructive sleep apnea. Their body wasn't able to activate that sympathetic response to wake them. And so they just stopped breathing, their oxygen continued to fall, and eventually it usually ends with a cardiac event. So there's a heart attack involved that eventually, because of lack of oxygen, increase in stress, they don't wake up. So I thought this was interesting. Just sleep apnea is in the center of 4 pretty major health conditions. So high blood pressure, heart disease, diabetes, and obesity, and you can see the overlap. And so you can have high blood pressure and heart disease, very, very common. But when you get into the overlap section, you can see what a significant amount of patients also suffer from sleep apnea, and so on and so forth. And so this is just to kind of show that sleep apnea overlaps with these 4 major conditions at least a 25 to 50% overlap rate, okay? So let's break it down a little bit. High blood pressure. It doesn't matter if you're calling it hypertension or high blood pressure, we're talking about the same thing. But one of the more common medical history questions we see yeses on is high blood pressure. And one of the reasons that it seems to be accepted is because blood pressure medication is very effective in reducing blood pressure. So, oh, you have hypertension, we're going to give you a pill for that. And then when that doesn't work, or it doesn't work as well, or it becomes resistant, we're going to switch it up, maybe increase the dosage or change to a new type. And everyone just thinks, oh, it's no big deal. We'll just take a blood pressure pill for that. And what we want to do is educate patients on the effectiveness of treating a sleep disorder, not only to decrease the medication use, but to have a long-term treatment option, right, that doesn't involve medication. So this is how it works. You go to sleep, you have that same apnea event, so this is identical to what I just showed you. So that oxygen level desaturates. So what happens is the blood vessels actually constrict, so vasoconstriction, to make sure that that precious oxygen, depends on how far you've desatted, but that precious oxygen gets to the brain and heart, because that's the body's job, is to protect those 2 vital organs. So vasoconstriction happens, which is the definition of hypertension and high blood pressure, is consistent constriction, increasing the pressure inside that vessel. So an apneic event is truly a high blood pressure event. It's the same thing, but it's happening over and over and over. So if you remember on that severity chart, a patient could be having 30 or more of these incidents an hour. So 30 times an hour, the blood pressure is having to be raised to compensate for that lack of oxygen. This happens consistently, and the patient develops lingering blood pressure, meaning it goes on throughout the day, and they're eventually hypertensive. So let's think about this a couple ways. One, if we could find a patient who was just beginning to have these apnea events, so we'll consider them mild, the consequence or the effect of the cardiovascular system is minor because it hasn't been going on long term. So if we could prevent that from continuing, we could treat them and not allow that disease to evolve or escalate because it's progressive. So if we could stop it before it got to moderate or then severe, we could prevent that patient from developing long-term hypertension. Right? So treating a patient's mild sleep apnea disorder or disease could actually be considered a hypertension prevention method. Okay, so that's how that works and why sleep apnea causes hypertension and why there's such a strong correlation. One thing I think is really interesting is it's bidirectional. This means that a patient with hypertension is predisposed to obstructive sleep apnea. So it's not just one way or the other. A patient who's already been diagnosed with hypertension has a 77% correlation with obstructive sleep apnea. And then, of course, the reverse is what I just showed you, which is a patient with obstructive sleep apnea has a greater incidence of hypertension. So both ways. So if someone's been recently diagnosed with hypertension, they should be tested for sleep apnea because we know that there's a 77% correlation. So it's very interesting. Moving on to diabetes. So another common epidemic, right? We see it all the time. We think of it as possibly as a perio condition. We talk a lot about that. But 7 out of 10 adults with type 2 diabetes have obstructive sleep apnea, and the correlation is 72%. So we know for a fact that any patient with type 2 diabetes should be tested for obstructive sleep apnea. We're taking 7 out of 10. Your odds are just too great to not be tested. And this is how it works. So during sleep fragmentation, which means the body is constantly in interruption, the sleep is going to be, you're sleeping normally, and then you don't breathe well, so your body arouses. Again, remember that cycle. It's called sleep fragmentation. It's disrupting the sleep cycle. And if you remember, I told you that deep sleep is considered a body sleep, and this is when hormones are regulated. So it's constantly throughout the night, the patient is getting disruption in their sleep, and their deep sleep is being interrupted. Their hormones can't regulate. So that's the consequence of poor sleep fragmentation or sleep fragmentation on type 2 diabetes. But then also, those oxygen desaturations are causing the blood sugar levels to increase due to the stress on the heart and the body. So a patient who's even a non-diagnosed diabetic will have higher blood sugar levels during the night due to their oxygen desaturation. The problem is it's not just the type 2 diabetes, it's the insulin resistance that's being caused. So when patients aren't responding to insulin and the body's not using the insulin correctly, it's a combination of these things. We're having the hormone inability to regulate and then the oxygen desaturation. So it's estimated that 422 million adults have diabetes. And this number is pretty staggering to me. According to the World Health Organization, 3.7 million deaths due to diabetes and high blood glucose. So this is when I say 5 minutes can save a life. A patient who comes to you that has these signs and symptoms needs to be sleep tested because we can see the correlation and we know the likelihood. This is just some percentages of association of obstructive sleep apnea and the heart. So you can see that the overlap is just so significant. You know, that anywhere, I mean, AFib, a 49% correlation, but congestive heart failure, which is a leading cause of death in our country, is 76% overlap or correlation. So one thing you might be asking yourself, and your patient might even be asking, and I often ask myself, is why is it that so few cardiologists are testing their patients for sleep disorders? And the truth of the matter is by the time the patient gets to them and they're in congestive heart failure, they're really not looking for root cause anymore. At this point, it's just about maintaining life, and they're focusing on that acute, in that case, acute heart failure or illness. You also have to understand that general doctors, MDs, and even cardiologists and certain specialists haven't been trained on sleep disorders. So unless they're following this, unless they're engaging in it, it's not common for them to have a protocol for doing sleep testing on their CHF patients. And that's true with endocrinologists, for your patients with diabetes. It's true for your GPs and hypertension. They're not trained to look for the sleep disorder. They're trained to treat the end stage disease, which is where these patients are in this category. So if you have a patient with heart condition, they should be sleep tested. There's no doubt about it. I don't ever present without talking about Alzheimer's disease. A dear friend of mine has early onset Alzheimer's, and it's very progressive, and he was diagnosed at 65. So this has been studied, and there's too many studies to even name. But what they have found is that dementia and Alzheimer's and brain health has been correlated to obstructive sleep apnea, depending on the study, over 50% correlation. So 50% is conservative. And what it is we talked about REM sleep being brain sleep. So in a normal, healthy brain, you can see the image there, the tissue is normal. Mild cognitive impairment, you start to see a blockage or some non-functioning cells. And then Alzheimer's disease, you see a large amount of dead matter or dead cells not functioning. But what it is the brain produces plaque, just like any other cell. It has a byproduct. And when we're in REM sleep, the brain tissue shrinks in size, fluid production is increased, and we're actually cleaning away the plaque off of these brain cells. What's happening in Alzheimer's patients who have sleep disorders is they're not getting the REM sleep that they need. And the plaque is staying there. The plaque is starting to occlude those tissues, and eventually there's no longer functioning. It's just plaque. So it's amazing, and that's a real simple way to put it. But this brain plaque is being built up, and it's being characterized as Alzheimer's disease. So again, if you know anyone who's suffering from Alzheimer's or has had that experience, you know that it's a life-changing, not only for the patient, but for the family. And the estimations on how significant Alzheimer's disease is expected to grow over the next decade is scary. It's going to be a huge problem in our country. So we know that if we can catch a patient when they're in their normal brain function, normal sleep patterns, and we can keep them from suffering from REM deprivation, we can prolong or potentially prevent them from having cognitive impairment and eventually Alzheimer's disease. Sleep in pregnancy. As a mom, I like to share just how important this is. And again, I'm going to say, why isn't sleep testing part of every prenatal visit? And it's just lack of education, lack of awareness. That's it. It's not because OBs aren't interested in the health of their patient or the outcome of the pregnancy. It's because they didn't learn about sleep in medical school. It was a very, very small part of their residency, if any, in their OB residency program. So understand that the studies are significant, that a patient that has obstructive sleep apnea is 3 times more likely to require a C-section and for their babies to require NICU time. So what we're saying is if a pregnant patient is having obstructive sleep apnea events, we've already identified that it affects your hormone regulation. It's going to affect your REM, just your cognitive function because you've got a disruption, but just the pure oxygen desaturation is directly affecting the fetus's breathing and desaturation as well. So we have to realize that what's happening to the mom is happening to the baby. So you can also take that a step further and don't think of pregnancy as just the time in which you're carrying the child, but think postpartum. Who more needs hormone regulation and good quality sleep and a time for their body to heal and recover than a new mom? And, you know, the hormone regulation takes months, if not years, after a postpartum time frame, after the baby's born. And so if we have a mom who's increased weight gain, already have fluctuating hormones, and they're suffering from some postpartum depression, they need to be sleep tested. We need to figure out what's going on and see if we can improve their sleep quality and have them just manage things better. So some of the risk factors that make you more likely to have obstructive sleep apnea while pregnant are listed there. So if you're already hypertensive or you're struggling with hypertension during pregnancy, if you have gestational diabetes, if you were already overweight before you were pregnant. So there's not necessarily saying that you develop obstructive sleep apnea because you're pregnant, but some of the risk factors are just increased. So maybe you already had mild apnea before pregnancy, it was just undiagnosed, and then the pregnancy adds to it, which then maybe evolves your apnea to more severe. Or maybe you didn't have any, but you had a little bit of resistance in your breathing, and that increased weight, that increase in mucous membrane and upper airway was enough to tip the scale, and now you are suffering from apnea. So it's not uncommon for our customers to have discounted sleep tests for pregnant patients, just to kind of try to get them moving and get them tested. Opioid epidemic, it's again, top of every article, it's everywhere, but this is drug overdoses. Now, Utah, which is where our company is based out of, is pretty conservative on the medication list as far as prescriptions for opioids that are prescribed. But we have anywhere between 300 and 400 accidental opioid overdoses a year. And accidental means that they took the prescription as prescribed and died. So when we think about that, that means that something else happened. Well, remember that apnea cycle. What if I was having an apnea event, my oxygen was desaturated, and I was on a breathing depressant, a central nervous system depressant like an opioid. So my breathing was already weakened by that medication. So that's already one strike against us. But that sympathetic activation is muted because that's what pain medication does, right? It actually mutes our pain receptors and our responses. So my body was trying to send the message to wake, but the opioids were blocking that connection. So I wasn't responding the way I should be to wake. So I've already depressed my breathing, and I've muted or weakened my response to the fight or flight system, and it's killing people. Okay, so personal experience with this, I have a couple dear friends who have had this happen, have died because they were already apneic. The one in particular was also fairly significantly overweight and had obstructive sleep apnea, and the combination killed him. So it's happening, and it'll happen to your patients and your friends and your family as well. So if we see a patient on a high dose of opioids or any other central nervous system depressant medication, we need to be thinking, hey, should they be sleep tested so that we don't potentially see them add fire to the flame, gas to the fire. So snoring. Lots of people associate sleep apnea with snoring, and a lot of people thinking snoring is no big deal, and that's just not true. They've clinically proven that snoring is not benign, meaning it is not harmless. So it inflames tissue, so the actual snoring is causing inflammation in the upper airway. There's proof that it disrupts blood flow. We know that it causes stress in the heart, affects the pregnancy, but what about the bed partner? If any of you happen to have a bed partner who snores, it's often just more disruptive to you than it is the actual snorer. So it's causing a lot of problems in America. Spouses are sleeping in different rooms. There's a lot of frustration because the bed partner is disrupting you. We call it the elbow syndrome, right, where you're not sleeping because you snore, and then your bed partner elbows you, which wakes you, you roll over, you both might get a few moments of sound sleep, and then it starts all over again. So you can snore and not have sleep apnea, and you can have sleep apnea and not snore, but the correlation is very high. So loud snorers are in about the 90 percentile. So if a patient is snoring loudly, there's a 90% likely that there's an apnea event going on. So if you're not asking your patients if they snore, you should be. So I like this slide, 10 leading causes of death in the U.S. I mentioned heart disease is the leading cause of death in the country. Cancer, we've already associated sleep apnea to both of those. And if I went down the list, I could continue to correlate all 10 top leading causes of death to obstructive sleep apnea. So when I say 5 minutes can save a life, this is what I'm talking about. I'm talking about a patient who has no idea that their signs and symptoms could be an indication of having a sleep disorder. And a few simple questions could shed some light on their risk factors, get them tested, and potentially not allow them to be one of these statistics. So today, if you have a concern about your sleep, so let's say that you watched an article, you read an article, your spouse told you, you're an educated patient, whatever it might be, you go into your medical doctor and you say, doctor, I think I have a sleep disorder. And if they agree, then they'll refer you to a sleep specialist. That sleep specialist will then send you to a lab, most likely. You'll spend a night in a sleep lab. During that time, they're going to be testing you, and they're going to be deciding if you're a candidate for CPAP. Once you've been tested and diagnosed and they've titrated or adjusted a CPAP to where they think it will work for you, then you're referred to a DME company. This is a supply company where they'll actually give you a CPAP, and they'll fill your prescription for that. Then you continue to be monitored both by the CPAP company and the specialist, and you're supposed to be reevaluated every 10 months, or excuse me, every 12 months. But keep in mind that there's some restrictions with CPAP payment with insurance companies. And if you are not compliant within the first 90 days, CPAP will not be paid by your insurance. And your insurance company will turn off payment, and the patient's now responsible for that cost out of pocket. So there are a few loopholes to jump through, and I won't go into any more detail. But then there's also replacement supplies every 3 months ongoing. And a lot of patients don't maintain their CPAP machine the way they should. There should be daily cleaning, monthly maintenance, and every 3 months, major parts are to be replaced. And I guarantee few patients are following those protocols. But just understand, before dentistry got involved, this is the only method in which a patient would get tested and treated for that sleep disorder. So you might also realize, why are so many people undiagnosed? because not very many people want to go through this. Not a lot of people are excited about this multi-step, expensive process that requires them to sleep in a lab and see multiple doctors. So that's one of the reasons that it's so undiagnosed. Keep in mind that the people who went through that process, right? So I was a committed patient, I was tested, spent the night in the lab, got my CPAP, made it through my 90-day trial, got fitted for the appropriate masks. It's estimated that 83% of those patients are non-compliant, meaning that they don't wear their CPAP at least 4 hours a night, 4 out of 7 nights. So they've set compliance standards very low. That's only half the night, half the days of the week, and you're considered compliant. And still 83% of those users are non-compliant. So that wasn't those 80% undiagnosed, right? That was the 20% that got diagnosed. 83% of those are not compliant. So really what we're saying is very few people are going through the process of getting tested and treated. And you'll see on this scale, this is a use of CPAP over weeks. And you're seeing that the severe patients are far more likely to be compliant, right? Because they have more symptoms, they're more scared, whatever the reason, they're being more compliant. But your mild and moderate patients, the more common category, they're far less compliant. And your mild, you can see, and just is not compliant very well at all. And just look at how quickly that first line of drop is at 12 weeks. So at 12 weeks, a large percentage of patients are falling off the wagon of using a CPAP machine. So this is what we suggest, is that the dentist has a screening protocol. And during your hygiene, new patient, or consults, you screen your patients as part of your dental exam. And this is a screen every patient protocol. So we don't pick and choose who to screen, we incorporate it into our everyday process. If the patient is at risk, their screening says so, then you have the option, depending on the state that you live in, of administering a home sleep test to that patient. Now, no dentist in any state can diagnose sleep apnea. You're not licensed to do it. It's considered practicing medicine. So what we've set up is a network of specialists who can read those sleep test results, will give you an interpretation and a prescription and a diagnosis. So the specialist is the one diagnosing the patient, never the dentist. So we're screening the patient. We're taking that screening, we're getting them tested, and we're sending it off to a specialist for interpretation. Within 2 days, you have a prescription back. You bring the patient in, review their treatment options based off of what the specialist recommends, and if the patient chooses to move forward, we impress, deliver, and adjust. Then we retest the patient with the oral appliance in their mouth to make sure that it's effectively treating that obstructive sleep apnea. And then if it was not successful, and after adjustments and testing we cannot help them, then we send them back to a specialist or CPAP provider so that they can get a CPAP as an alternative or additional treatment. So that's the dental process. So what we know is that the patient doesn't have to go be their own advocate to determine they're at risk, because you would be their advocate now. You're going to be the one looking for the signs and symptoms. We also know that providing a home sleep test solution is far more efficient and easy and much higher case acceptance for the patient. And we know that oral appliance is a preferred treatment option for most mild and moderate patients. Compliance with oral appliance is significantly higher than that of CPAP. Now, there's not a ton of statistics out there to compare because oral appliance is still considered relatively new, and there's such a variable in the type of appliance. To see true compliance is challenging, but the statistics are there to say that oral appliance compliance is significantly higher than that of CPAP. So this is what we're proposing you do. So we've broken this down into a workflow where you screen the patient, you test the patient, you give them their financial options, you treat them, you deliver the appliance, and you follow them up routinely for care. And then we complete this cycle over and over, and it never stops. We don't treat a patient with an oral appliance and then say, okay, great, never talk about it again. We're going to constantly rescreen them to make sure that it's working, also to make sure that they haven't developed any new health conditions or risk factors that we need to take into consideration. People don't sleep the same the way that they did today as they will in a year or two, and even their health won't be the same. So it all starts with screening. And as dentists and dentistry, screening is really our wheelhouse, almost more than any other industry. So for caries screening, right, we take x-rays, you do an oral evaluation, maybe an Explore, maybe you're using some tools like a Devdent or Carie View, right, you're screening for caries. We don't take x-rays because we know they have caries. We take x-rays to check for or screen for caries or other dental disorders. Same with perio. We can do perio charting, we can do genetic testing, there's saliva testing, but we don't perio chart because we know the patient has perio. We do it to see if there's a periodontal condition or to check the health of their tissues. Sleep screening is going to be very similar. Medical history, extraoral and intraoral exams, and we're going to talk to the patient. We're going to have an interview. Again, we aren't doing this because we assume they have a sleep disorder. We're just screening them for their risk factors. It truly is the key to success is screening. And as you look at your patient base and you go back this afternoon and see your patients, you cannot only look for your overweight, unhealthy male patients. Okay? That's a stereotype that has to be discredited right now. So you are really limiting your search for if you're only looking for sleep in patients that are male, overweight, or older. We see in our sleep clinics just as many female patients in their 30s test positive for sleep disorders as we do male patients over 60. So I want you to first and foremost get that stereotype out of your head. So we're going to look at their medical history. So how do we identify who is at risk? We're going to look at their medical history, and we're going to use those very similar to that list I showed you first off. Those who have had a stroke, diabetes, hypertension, acid reflux. Acid reflux is really common, right? So there is a reaction to having your airway blocked. It's a positive pressure situation. You're trying to breathe normally. Your lungs are still trying to breathe, but you have nowhere for that air to go. And it's causing negative pressure, and that acid is coming up into the esophagus because out of the stomach into the esophagus because of that negative pressure. Headaches, I underline that one because it's one of the most common conversations we see in a dental practice, and I'll show you why. Thyroid, we're talking hormones. Pain, we know pain, it disrupts sleep. Sleep doesn't allow you to respond as well to pain. If you're having any changes in mood or irritability. Now, if you have a large neck, if you are a woman who has a neck that's greater than 16 inches, you are at 90% likely to have a sleep disorder. A male is an inch larger at 17. That's a big deal. So if you see a patient whose neck is large, they should be tested. They don't have to have any other symptoms. That alone would do it. Age and gender, BMI, and pregnancy. And then sleep specific. And you guys might already have all of those other things on your medical history, probably not neck size. And I don't know if you guys are asking for height and weight, but you might have most of those. The sleep specific, you probably don't have very many of these. So this is our daytime tiredness, snoring, known to gasp for air, morning headaches, frequent awakening, insomnia, sleep deprivation, or difficulty staying asleep. So this is going to be the sleep questions that you need to have added to your medical history. These are questions you should be asking your patients to screen them for sleep disorders. And again, I asterisked daytime tiredness and snoring because those are very common and very motivating topics to talk to your patient about. So as a company, Imagine Sleep has developed a screening tool. And we've taken into consideration these health conditions, the AFib, the stroke, acid reflux, diabetes. We've taken all these into consideration, and we've weighted them and scored them. Now, we've added one more step to this because we've talked a little bit about head, neck, and jaw pain because we know that sleep and TMJ or TMD are directly correlated. It's been proven that sleep apneic patients have increase in bruxism, and bruxism can be a sign or symptom of a sleep disorder. And we know that that can cause TMJ pain, can cause problems. So we as a company take TMJ and sleep and put them as, you can't really treat one without the other in our minds. So we've asked these questions of our patients, and then based off of their height and weight, which calculates their BMI, their age and their gender, we score them. And it creates a number that our hygiene team or our clinical team can look at and say, without question, what risk category they're in, low, moderate, or high risk. So I'm going to elaborate on this just a little bit more. So here is just a patient. So this is a medical history that we use in our clinic. And we ask these patients these questions. And we still ask about liver disease and blood disorder and epilepsy and all the things that you still have to ask for. We're not suggesting you stop what you're doing, but we're suggesting you add a few more. BMI, height and weight being one of them, neck circumference being one of them. So this patient listed 14 conditions that were directly related to her poor sleep. I mean, we could tie each one of these back. And if you look at her medication list up there, that was before she handed us a piece of paper and said, here's the rest. So this is a pretty sick patient, right? She came to us, she had not been treated for her sleep disorder. So she came in with this kind of medical history, has obviously seen countless doctors, and was not being treated for a sleep disorder. So obviously she had obstructive sleep apnea, and based solely off of her symptoms, she should have been tested. But our goal with this patient, we are following her closely. Our goal with this patient, she actually went to Mayo Clinic in Rochester and was moved there so she could be closer for evaluation. But we're looking to get her medications reduced. That's our goal. We want her to have enough energy to have do more. Her daily exercise was going to get the mail. So we wanted to increase her energy so that she could be more physically active, and we wanted to decrease her medication use, and that was our goal. So I asked her if that daytime tiredness, and this is some verbiage I gave to you, just a suggestion. How many days a week do you wake feeling rested? And I would just ask that. The patient marks daytime tiredness. How many days a week do you wake feeling rested? And then I explained to them daytime tiredness is common, but it's not normal. So you guys can all understand, if you had a good night's sleep, 6, 7, 8 hours, you should wake feeling rested and have plenty of energy to last throughout the day. We know that 7 to 8 hours of good quality sleep will get us through the other 2/3 of the day. But yet, if you talk to your patients or even look at your own team, the number of patients who are suffering from daytime tiredness is staggering. The need to take a nap, the need to supplement with caffeine, the need to avoid doing certain things because you're just too tired or don't have the energy. So don't let daytime tiredness fool you that it's normal. It's common, but it's not normal, and it's not an indication of good quality of sleep. So here's some examples for verbiage for hygiene or new patient appointment. So first one with headaches. I noticed you marked headaches on your medical history. How often are you having headaches? Patient will respond, oh, once a month. Okay, so do these headaches affect you much? Well, yeah, when I have these headaches, I can't go to work. Okay, but they're only happening once a month. Well, once a month are the ones that are really bad, but I get at least a mild headache every day. And you guys all know exactly what I'm talking about. Once you start digging into your patient's medical history, all of a sudden the truth comes out, right? So, okay, so now we've established you have daily headaches, okay? So are they ever morning headaches? Like, do you have a headache when you first wake up? You know what, yeah, a lot of mornings I wake up right out the gate with a headache. So now stop and ask yourself, if you had a good night's sleep and rested, should you wake with a headache? And the answer is no. So understand that the correlation between headaches and sleep disorders is significant. So we have a combination of bruxism, TMD, and sleep disorder that's all affecting our headaches. And headaches are a very common symptom. And I'll tell you, as a headache sufferer myself, it's a game changer. It's one of those things that if your patient marks headache on their medical history, you should touch on that. Then I would go on to say, I don't know if you know this, but headaches are commonly associated with sleep disorders. We call that planting the seed. This is where we've explained to the patient that we know something about their headaches or whatever symptoms they're having, and that we can tie it back to sleep. So moving on, based off of your medical history, you have some risk factors associated with a sleep disorder. In fact, based off of our sleep screening, you are at high risk. That might be your only conversation in hygiene that's necessary. They may not want to go into every risk factor they have. You may not need to bring up their type 2 diabetes or their hypertension, because in the back of their mind, they already knew they had a sleep disorder. So it's okay to say, based off of the questions you provided and answered, you're at high risk. And that's where that imagined sleep screening comes in. Here's another one. I noticed you marked snoring on your medical history. Is this something you are personally aware of, or has your spouse or bed partner mentioned it? The reason we ask that question is because now all of a sudden they start to bring in their spouse or their bed partner. And we bring it back to, this snoring is not just affecting you. And it's not uncommon for the husband to say, you know what, it affects my spouse more than it affects me. My wife would love you if you could help me with my snoring, because they're sick of getting elbowed or hearing it, right? So keep in mind, bringing that bed partner back into the equation can just help strengthen your conversation. And then you could go on to say, I don't know if you know this, but Dr. Smith is trained in appliances that can actually help with your snoring. So a lot of people don't realize that there's snoring treatment options out there. And if they do, they might think they're surgery. Not a lot of people realize dental appliances or oral appliances can be used to treat snoring. So just planting that seed. And then I'd finish the conversation something like this. Dr. Smith is going to want to talk to you about getting tested. So we aren't diagnosing anything. We're not recommending treatment. We're saying that we know, based off of the signs and symptoms the patient is reporting, that our doctor is going to want to talk to them about getting tested. All I've done is plant the seed, and I've allowed them to start thinking. And that way, when Dr. Smith comes in, the patient's already maybe had a question or two or is already set up. So another example, the only way to know what's going on is to test. So I love that. A lot of people think, oh, it's not me, I doubt it's me. Oh, I don't know if you're right. Well, that's okay. We don't have to know if I'm right because we can test you. So luckily with the technology we have today, you don't usually have to go to a sleep lab. You can actually wear a sleep test at your own home. That right there just puts some huge barriers out of the way for that patient, because very few patients realize home sleep testing is an option. So they've avoided that sleep process because they haven't wanted to spend the night in a lab. They haven't wanted to go to a hospital and sleep in the, the glass room that they anticipate it would be. Another option, good news. Dr. Smith has been trained on sleep and has some options for you. One is a home sleep test you can rent and wear in your own home. So this is just planting the seed, getting the conversation started. I'm going to, obviously these examples are if you have a testing solution. If you choose not to test in your own office and choose to refer, you just tweak them just a little bit, right? Great news, Dr. Smith has a relationship with a specialist who specializes in sleep treatment. Let's get you sent over for a consultation. That would be it, okay? If you know that sleep specialist offers home sleep testing, you can go ahead and follow it up with, and great news, because of the technology advancements, the specialist doesn't usually require you to spend the night in the hospital. They can usually test you in your own home. So you can tweak those just a little bit depending on what your protocol is going to be. So we've talked about their medical history, but then as a dentist and dental team, we also have signs and symptoms that are inside the mouth. So if your patient is showing these signs or reporting these symptoms, they have additional risk factors. So if a patient has a large tongue, large tonsil, if they've had their bicuspids extracted and so everything is moved back and is smaller, they have high palate, if they have retrognathic mandible, any of these things are signs and symptoms. And symptoms are going to be your popping, clicking, your jaw pain, your even dry mouth and chapped lips. Those are indications of patients that breathe through their mouth. So these are things you're already seeing, I'm certain. You're probably just not thinking about them as indications of having a sleep disorder. So I would challenge you to just think about it a little differently, and maybe there's more going on than just a perio condition or something like that. So this is an example of an intra and extraoral exam in our software. This shows you tonsils and Malampati. This gives you some posture, some muscle ideas. This will just help you chart all the things that you see and remember what to look for. And this is just part of our software. Here's an example of a scalloped tongue. We look for lingual tori, so some clinical examples. So you have two choices. I hope that you take this information and say, that you could spare 5 minutes in every new patient or hygiene to further evaluate your patient's medical history. And I use this example because I don't care whether you treat them, meaning you test them, get a diagnosis, and provide an oral appliance, or you refer them. I don't care. If you never want to do a sleep appliance, that is fine. But at the very least, you need to be identifying them through screening and referring them. And it's no different than if you are a general doctor who doesn't treat ortho. You don't avoid looking for it. You still identify patients who would benefit from ortho. You just refer. Same with third molars, endo, oral surgery, and sleep testing. So you identify your patients and what they need, and you either keep them internally, test and treat them, or you refer to the specialist when appropriate. So that's my challenge to each of you. This slide just says why sleep treatment and dentistry. The signs and symptoms show up in the mouth. As a profession, we are the only ones that can impress and deliver an oral appliance. So what that means is if you do refer a patient to a specialist, the likelihood of them getting prescribed a CPAP is very, very high because sleep specialists cannot provide oral appliances. All they can do is write a prescription for one and then try to find a dentist trained to treat sleep. There aren't a lot of them. So you need to ask yourself, do I want to be one of those dentists who are trained to treat sleep, or do I want to find someone in my community and refer to them? Dentists are seeing the public far greater than those that are seeing the general doctor. We're the ones trained to evaluate above the shoulders. That's our area of expertise. Our treatment option is the most cost-effective and conservative. So an oral appliance is less expensive and more conservative, not to mention far more compliant than a CPAP. And then also the organizations that govern dental sleep medicine, that's the AADSM and the AASM, have recommended oral appliances for the treatment of obstructive sleep apnea. So the industry is behind us. And then the ADEA adopted their statement in 2017 that said dentists should be assessing a patient's risk for sleep disorders. And it should be part of your comprehensive medical and dental history. And then you should either refer for testing, you can do internal testing, and then you should treat when appropriate with an oral appliance. So the ADA has now said, here's our opinion on what the dentist's role should be. As a company, Devdent, we offer a number of solutions to help you. First and foremost is the education, the training, and implementation. This is a really big step in the right direction for sleep medicine. It's been a struggle for offices who go to a 2-day course and then try to implement sleep without tools and without assistance. And so, again, we've learned from our own experience and others and developed a system that will help you implement sleep. We have Imagine Sleep software. It is a cloud-based software, but it also has a Dentrix connection option. So you can use it with Dentrix or without, depending on what software you have. But it handles all aspects of dental sleep medicine. So it's going to handle your screening, your intra and extraoral exams, your tracking, your letters, and then it has a direct connection to our other product, which is Imagine Billing. Imagine Billing is a cloud-based medical billing software and service that was built specifically for dentistry. So it handles all of your cross-coding. It handles all of your verifications, pre-authorizations, claims, and appeals. So you can outsource to Imagine Billing. We provide you the software for free, and you use our service to automate medical billing in your practice. And that is not limited to sleep treatment. That can be perio, oral surgery, CBCT, any procedure related to an accident. The list of Imagine Billing options is exponential. This is what the software looks like inside of Dentrix. Every patient actually gets an Imagine Sleep tab inside their chart so that you can complete that screening and intra and extraoral exam without ever leaving Dentrix. Online, we offer tablet options so that you can have your patients complete their sleep screening on the tablet or on paper or in Dentrix, it doesn't matter. They sign right on the screen, and then we calculate the patient's sleep score or what their risk factor is. We have the intra and extra oral, which I showed you. This is all clickable options, so you don't have to go back and make a lot of notes about what you find. You can just click through them. And then that actually produces an auto-populating SOAP note. So we take that intra and extra oral exam and we put it into sentence format SOAP notes for you so that you can document and bill medical insurance. And then we have the process, and this is implementation. Do you have your consent? Do you have your form signed? Do you have your letter of medical necessity? And we track and help you create all those documents. And then this is what the billing software looks like. You put in the dental code, and our software cross-codes it to medical for you, so you don't have to memorize all of these different procedure codes. And then we do the same thing with the diagnosis code, and we show you what codes are applicable for that particular procedure and help you choose the appropriate one. So where to start? We recommend clinical training. You need to know the basics, so we recommend you take one of the Devdent courses. Then you have to figure out how are you going to get your team involved. Are you going to take them to a course? Are you going to do online training or on-site training? How do we get your hygienist and your clinical team to understand this? I will tell you that implementing sleep fully into your practice is a team approach and cannot be done without some team involvement. Then you need to ask yourself, how are you going to screen, track, bill, test? You need to come up with some processes, select a software or partner for that, and then you need to go through your implementation. And this is literally, what are we going to charge? What's our protocol going to be for return appointments? How are we going to handle specialists in our community? And this is the protocol. So Devdent does have a solution for every one of these, whether it be our courses, our team training, our software, or our ongoing coaching and implementation. So if you're interested in implementing sleep, we certainly can help you do that. We have the 2-day course, which is called Dental Sleep Medicine Simplified. We have 2 courses left for this year. We have one next week in Las Vegas, and I think there's a couple seats left. And then we have one in December in Nashville. And then we'll be sharing our 2020 calendar here shortly. Registration is still pre-registration, so it's $4.99 for the first attendee, $3.99 for the second attendee, and it's 2 days, 13 CE credits. And every provider gets a complimentary one-night sleep test. So we actually take a sleep test machine for each doctor, and you wear it on night 1, get to be tested, screened. We walk you through the whole process so you get that hands-on experience. And then Start Medical Billing and Boost Case Acceptance is our 2-day course for medical billing. This is where we show you all the different procedures in medical that can be billed, in dental that can be billed to medical, as well as examples and protocols. And you leave with a 150-page workbook on how to do this. Same prices are available. We are running out of room quickly in the 2019 calendar, but there is one course left in December. So this is the end of my presentation. You can join our Facebook group if you're not already a member. It's called Medical Billing for Dental Practices Imagine Billing. It's a free group. It's not a sales group. It is about medical billing, helping each other, learning from each other's successes and failures, and our coaches monitor that and help answer questions. If you have a really detailed question, again, you can email support@devdent.com, or you can call our customer service. And they can help answer any of those questions. So I'll go back and see if there's any questions I can answer before we end this. Please let me know if you have any. Thanks so much. And don't forget, in a matter of minutes, you'll be receiving our free resource via email. Thanks so much.